All right. With that, I would like to introduce you now to our lead implementer from HEALTHQUAL. He is board certified in infectious diseases, a professor of the Division of Epidemiology, Institute for Global Health Sciences, University of California, San Francisco, to talk about HIV stigma and discrimination in healthcare settings. Please welcome Dr. Bruce Agins.
Hi, and thank you, Kate, and welcome everybody. I'm really excited to reinvigorate the Stigma Quality Improvement Learning Network here with you this morning, and look forward to your participation. Special thanks to the whole SHIP team, and also to those behind the scenes, Michaela Bravo and Jackson Lee from UCSF, who support the work that we do and make it possible. Also, special welcome also to Todd, as Kate has mentioned, and also our fellow implementing partners who are here today from EPIC and ICAP. Very glad that you were able to join us. What I'm going to do today, as I attempt to share my screen, is give you some background, taking the somebody else has to stop screen sharing. I did. I was able to do that. Okay. Really to build upon the big picture framing of policy that Louis gave us to now hone in on the healthcare settings, and to give you a sense of sort of the parent network and background for this network. I realize some of you may have heard the basics of this if you participated in the earlier network. However, there has been some activity since then, and I'm going to update you on some experiences from the multi-country network. On this particular screen, you see a picture from our last network meeting at the end of last year, and you'll see some familiar faces from SHIP in that picture as well. This network is supported through funding currently from Gilead and ViiV, and is a partnership with UNAIDS and APN Plus. It was previously supported through PEPFAR and HRSA in the earlier phase of implementation. So what I'm going to talk about is what we do and why we do it, to give you some very quick examples of the national and subnational activities, and then hone in on some practices at facility level that will extend what Kate has described from the Philippines, and then close by some thoughts about what we need to do to make this a routine activity. So I think, first of all, the question is, well, why do we want to apply a quality improvement approach to stigma reduction in healthcare settings? As I think you know, stigma is a social process that requires systemic action. And so we need to focus on the systems of care and not just individuals. We know that the drivers of stigma are common, but their manifestations are often contextual, and we need to adapt interventions to the context of the organization where we work. The process of scale up and sustainability are inherently dynamic, and that means we need a structured way to learn as we go. We know that programs already support quality improvement, so we need to harness that existing capacity while layering on new capacity. And most importantly, quality is co-produced, and we need to promote partnerships among communities, providers, and governments working together as we advance improving and reducing stigma reduction. So very quickly, I'm going to share some frameworks and principles with you. And this is the Health Stigma and Discrimination Framework developed by Anne Stengel. And as you can see, it recognizes that stigma operates at many different levels at the same time. It is represented by manifestations in practice and experiences, populations and organizations, and there are many drivers and facilitators with interplay at all these levels of the individual, interpersonal, organizational, community, and public policy level. But with our work, we're honing in here on organizations and institutions, health condition-related stigma, and again, at the organizational level. This framework was adapted from Laura Nyblade's work. And Laura Nyblade is the researcher from RTI who developed the healthcare worker stigma survey that we'll be using in this network. And as you can see here, there are immediately actionable drivers related to producing stigma and discrimination. And those are fear of transmission, awareness of stigma, attitudes, and the institutional environment itself, which can all lead to different kinds of stigma, whether it's experienced, whether it's anticipated, preventing us from accessing services, whether it's perceived or internalized stigma, which can lead then to avoidance of services, to harassment and behaviors, and refusals to treat. And that can, of course, affect all of our steps in the HIV prevention and treatment cascade and prevent us from reaching our epidemiologic control targets. And again, to focus on the fact that there are immediately actionable drivers that we can work on, which I think is a far step from the early days of thinking about stigma, where people said, well, we can't do anything about it. Stigma also relates to what we call the fourth 90, related to health-related quality of life. It's important to recognize that the 390s are not enough, that we want to focus on people-centered care, and we want to focus on making sure that people who live long and healthy lives with HIV have good health-related quality of life. And so we want to think about that fourth 90 as we go forward and reduce stigma and discrimination. From the quality lens, we like to think about equity. Equity is one of the key pillars of quality in the framework of the Institute of Medicine. And it means that we provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, socioeconomic status, and a medical condition. And we also know, here citing the Lancet Commission on High Quality Health Systems, that quality of care is worst for the most vulnerable groups, including the poor, the less educated adolescents, and those with stigmatized conditions, who are often at the margins or the edges of the health systems. And that makes our work extremely important. In our work, we'd like to show this Venn diagram that brings together the intersection of technical quality, which providers think of most often related to effective care and viral load suppression and safety, and the experience of care, which is the patient or client's perception of quality of care, which focuses again on the domain of equity and people-centeredness, all four of these being key domains of quality. Now, this diagram explains the way in which we operate in the network. And if you'll, I'm going to walk through with you this diagram. Now, typically in quality, we focus on clinical performance data and looking at things like viral load and viral load monitoring, diabetes monitoring, and so forth to lead to better outcomes. And in this network, we want to encourage that, particularly with emphasis on the disaggregation of data by key population, by age, by other groups and behaviors, so we know where exactly our challenges are with quality that we can focus on to improve quality of care. But we're also going to look at quality related to the healthcare provider surveys, and by getting patient feedback, both on the experience of care and health literacy. And this allows us to unite different streams of data to give us a much more comprehensive snapshot of the quality of service delivery. And more recently now, we're able to add community-led monitoring data to the mix when it's available, which also gives us an important lens on the quality of care in an institution. In our network, we work at the multi-country level. That's how we've been funded. And this diagram just simply shows that the data from the national level, such as what you're capturing here, is produced from the data at the facility level, which each organization will generate, and then can be reported back at the multi-country level. I also want to take a moment to be clear about what I mean when I talk about quality improvement. Quality improvement is a formal discipline. You're going to hear a lot over the years of different models and methods of QI, but they all come back to these core and fundamental principles, namely that every system is perfectly designed to achieve exactly the results that it achieves. And if we were in person, I'd stop here and ask you the question, well, if we want to change, what do we need? Where do we need to operate? And of course, if we want to change our results, we have to change the system. And that's how we use the tools and methods of quality improvement, which means reducing variation, understanding our work in terms of processes and systems, developing solutions by teams of providers and patients so that everybody who's involved in a process can contribute to understanding the causes of problems and unpacking the process. We focus on patient needs. We like to test and measure the effects of our changes so we can put into practice those that work and avoid putting into practice those that don't, and then build upon peer learning. And that's the beauty of a network like this, where what you do at your facility can be shared with all the other participants in the network. And we know from experience that this accelerates learning and change and improvement. And that's why we bring people together in teams in these networks, appreciating that it does take time from your busy schedules and patient care, but the idea is that it will help all of us do a better job at our work. Our own vision for quality rests on this particular framework, which is the HEALTHQUAL model. And in it, we look at the yin-yang or balance between measurement and improvement. It's not enough to just measure and report, to measure and talk about the methods of measurement. It's important to think about how we use that data to improve care. But it's equally important to not just improve care by saying, I've got a great idea, let's do it, and then we do it, if we don't measure what we do, because we don't know, again, if what we put into practice works and achieves the results that we want to achieve. That bottom base platform, the trapezoid, is what we call the quality management program, sometimes referred to as an infrastructure. And that is characterized by the structures, functions, and processes that support the improvement and measurement activities. So things like leadership involvement, like the committees that look at quality, the quality teams, the knowledge and capacity building of staff in the facility, and the involving of clients in the process. And ILDE will be working with you as a coach to focus on these different aspects to support your quality improvement program. So turning to specifics, the NIBLADE survey that I mentioned has 51 items, and obviously that's a little challenging to do on a frequent enough basis to improve care. So when we started our network, the country teams came together and prioritized 8 measures. These 8 measures, which will be used here, include whether in the past 3 months you've observed healthcare workers unwilling to provide care or actual providing poor quality of care, whether you avoid physical contact when providing care or wear double gloves routinely when providing care, whether you're worried about getting HIV from drawing blood, whether you have written guidelines and enough supplies in the facility to avoid risk of infection, and do you agree or disagree that women living with HIV should be allowed to have babies? So the work of our multi-country network occurs, as I mentioned, at the national level, and I'm not going to go into detail at the national level, but just to show you one example from Malaysia, where they brought together from the Ministry of Health, the HIV program, their quality unit, which is based at the HRSA, and civil society through the Malaysian AIDS Council, and they designed their national QISD program. And they actually brought it to scale unbelievably rapidly and have now spread across the country, with having a site in each state in Malaysia. And they've really done a wonderful job. And this just gives you a scenario that we'd love to see happen here in the Philippines with engagement of the Department of Health. In the meanwhile, working with SHIP to help move this forward through the network. There then also is subnational implementation, where at a more local level, there can be sponsorship and championship of the quality improvement stigma work. This is an example from Songkhla province in Thailand, where the project was started off in 2 hospitals, but the leadership realized that what was happening was important for all hospitals. And so they adopted policies in their province to cancel the special codes that identified people with HIV, conducted training for healthcare workers across the province, added in specific HIV information in the routine infection control training, and identified champions who were then integrated into their quality teams in the facilities. So again, just some examples of the kinds of changes that can be made. This example is from Vietnam and Thanh Nguyen province, which adopted the mantra of a stigma-free province. And they expanded from 7 to 11 sites, had refresher trainings on stigma and SOGI for all sites, and then supported a model of community advisory boards, which I'll touch upon briefly, and I hope will be a topic of more in-depth discussion, benefiting from the experience that Todd brings to this at a subsequent network meeting. I want to go into a little more detail, however, at the facility level. Now, this is an example of a storyboard from Thailand, from Pompisai Hospital. And in this example, and what you see here is that in their survey of patients, they identified several areas of concern, which included open discussion about patients in public, separated waiting areas, labeling equipment so that it was obvious that it was being used for people with HIV, and unnecessary masking and putting people with HIV at the end of the queues for care. You can see their initial results here. And then what they did was they conducted a root cause analysis using a driver diagram, which is here, and identified the areas and the interventions that they wanted to test to address them. And so again, here you see the removal of the codes and the training, and then the improvement in their results. Obviously, we could go into more detail about this, but don't really have the time to do that. But I also wanted to show, for those of you that work in hospitals with multiple service areas, that this can affect other units in the hospital. And here is an example from Hat Yai Hospital in Thailand as well, where they use their diagram, driver diagram, and then identified interventions to address the challenges identified, which again are here with removal of signage, reinforcing universal precautions, education, and again, reinforcement of guidelines. And so here you see a marked improvement in results once they implemented these changes. The other part of our measurement is on patient experience, and there are many different ways to do this. We don't prescribe a methodology, but recognize that this can be done through surveys, through exit interviews, through patient forums, through storytelling, comment boxes, and through the consumer advisory boards. And to facilitate this process in our network, we had a group that developed common measures for patient experience, which are here on this slide, about whether information was explained clearly, was the clinic welcoming and friendly, were you treated with respect, was privacy and confidentiality observed, did you experience discrimination from a healthcare provider or other staff member, were you involved with decision-making about care and treatment, and did your provider spend enough time with you? And here's an example of application in Lao PDR, where they conduct their network in every province of the country as well. You can see that there was that the results were really quite strong here in Lao at the hospitals participating in HIV care, and they also looked at what they called index of engagement, and you can see here also the results are pretty strong. I should point out that because they look at results from different facilities, that we know that in Lao there are 1 or 2 facilities where there are still some problems, and they account for the lower scores here. At Champasak Hospital in Lao, they collect their data through comment boxes, and you might think, well, nobody ever puts information in the comment boxes and looks at them. But in this hospital, they look at it routinely, and their quality improvement committee looks at the responses every week and then identifies interventions based on that. And so they had interventions based on this, focusing particularly on registration, where sometimes people were not as friendly as they could be, and they They were then, all the staff were trained to give a very friendly greeting. They trained staff on policies and talked again about transmission. This is just an example of the work in Laos, and again, improvement over time in their data. Now, Vietnam has done a lot of innovative work in this area, and there are 4 different ways in which they look at client input. One is from the community scorecard, another is getting client feedback from hotlines and comment boxes, community dialogue led by community advisory boards and others, and then exit interviews, as I mentioned, to get qualitative information, which is very helpful in identifying specific concerns. In the community advisory board, in this particular example, the community advisory board, or CAB, identified concerns from clients at the facility, and as a result, changed their processes. They created after-hour services for people that couldn't come during regular hours. They developed a navigation system. They expanded the flexibility of services in general, and they helped to promote access to social health insurance as it was rolling out in Vietnam. So a really impressive example. And as I said, we hope to go into more detail later on. Now, Vietnam has also been a leader in looking at literacy and U equals U in their quality work. And again, it will be another topic to focus on down the road. But you can see here improvement in the number of people familiar with U equals U or ever heard U equals U messages. And with respect to literacy, here's an example of a PDSA cycle where they realized that the number of people that actually knew their viral load results was low. And we know that understanding your own healthcare data is empowering and leads to better adherence. And we also know that it will be an important factor in implementing U equals U. And so they started off by providing leaflets for patients, and the head of the outpatient clinic reminded staff to provide counseling on their results. They showed some improvement, but not enough. And then what they decided to do was have the staff provide the results and counsel the meaning of the results for patients as they've done the test. They targeted for people that had just done their viral load test. And then they set up a reminder system for counseling on U equals U and called people to check to see if they actually understood and remembered their results. And that resulted in a significant improvement up to 84%. A lot of food for thought here. And then briefly, I just want to show you what this might look like if we look at findings that are not optimal in health outcomes, whether experience or clinical, and we understand that patients are saying that they weren't treated with respect, or they might be missing appointments. So we want to break this down into PDSA cycles or improvement cycles to focus on how we improve this and address this root cause of stigma and discrimination. So their change ideas in this facility were a friendly greeting to eliminate putting the patients at the last part of the queue, and the labeling of documents. And so what this means is that in a PDSA cycle, you can actually measure the number of times that you've implemented those changes, which means that you can show causality from your changes to your result. And that's the beauty of the PDSA cycle methodology. And again, that will be reinforced through coaching. We also call this sub-process or step measures. Here's just a summary which we can share with you about interventions that have been tested in the countries across the network. You can see that they span across a number of different categories in the organization related to how care is delivered, related to knowledge management and decision support for providers, performance measurement strategies, people-centered care strategies, and strategies overall in the organization of the health system. So, how do we make QI a routine element of stigma reduction? Well, what we've learned from doing some small evaluations of the work is that there are a number of different strategies that can lead to sustainable focus on quality to address stigma reduction. So first is co-production. And what we mean by this is actually involving your clients in the processes of looking at the systems and designing the improvements to change them, and being on the teams to help monitor the process and participate. We call this consumer involvement back in the States. There are a number of names for it, but in the quality literature, the term is usually co-production, and that can refer to co-design, co-implementation, and co-evaluation. Leadership support is key. This may be a challenge in large hospital institutions where stigma may occur in different parts of the organization, but getting buy-in from the leaders, I think, as you saw from some of the examples from Thailand in those hospitals, is absolutely essential. Having a designated stigma champion is another key to success. So somebody who just every day thinks about how they're going to manage the stigma process and the QISD process in the institution. Having a formal plan and a formal task team or committee that focuses on stigma is another helpful strategy. Visualization strategies are critically important as well. And one of the comments that people often say, especially those from key populations when they walk into a hospital, is, well, when we see literature about HIV or prevention, we don't see people who look like us. And so having posters around that include people who look like those affected by HIV is really critical. And we saw this, by the way, at BioCore in the social hygiene clinic, where the posters were very KP friendly. Routine elicitation of qualitative data is also very important. So yeah, surveys are great. You can get some basic information, but you want to unpack those surveys. If somebody says that they're having a problem, you want to be able to talk to them and say, well, where did that happen? Can you tell me more about that? Because that will then help you target and tailor your intervention. So thinking about the best way in your setting to get qualitative data, whether it's from focus groups, exit interviews, whether it's from some other methodology, I think is really quite important. Aligning the stigma reduction work with other campaigns like U equals U is another helpful strategy. And paying attention to intersectional stigma, again, another huge topic for another time, related to how other, whether it's the intersection of HIV stigma, mental health stigma, KP stigma, PrEP stigma, youth stigma, there are a lot of different things that come into play that intersect and affect behaviors and healthcare outcomes. So I think that's the end of my formal presentation. I always like to shout out to Thailand because they really have adopted this as a national strategy. It's extremely impressive. And in this group, with the exception of the two folks in front, you can't tell who is from the Ministry of Public Health, who's a provider, who's a consumer. And there are people in this group that are very high-level officials in the health system that have joined in this activity. So in conclusion, we know that we can apply quality improvement routinely to reduce HIV, stigma, and discrimination. We can integrate data from both patients and healthcare workers into these routine activities. It's critical to disaggregate our performance data by key populations so we know if there is stigma where we need to focus. Activities to assess patient experience and treatment literacy through common indicators are an integral part of reducing stigma and discrimination. We've identified over 27 strategies that address the 4 immediately actionable drivers of HIV-related stigma, leading to evidence-informed interventions. Extremely important is to know that HIV-related stigma and discrimination in healthcare facilities is actionable through organizational and system-level changes, and that sustainability in healthcare facilities will require ultimately the integration with the national policy and program activities. And as Louis presented, I kept saying to myself the whole time, wouldn't it be great if there was a pillar in that policy and regulation that included routine application of quality improvement and vigilance, so that we can address stigma continuously in the healthcare settings. So I thank you for your time and attention. Just some pictures from our meetings. As I've mentioned, some of our funding comes from Gilead and ViiV, and I want to acknowledge our sponsors, as well as the enormous number of people that have contributed to the work that we've done from all of the participating countries and contributed to the knowledge that we have and that we hope will advance through this network as well. Thank you very much.
Thank you so much, Bruce. That was definitely a great way to run us through the experience you've had and the background of QI, especially in stigma and discrimination. So I loved what you said one time during one of our site visits. I think you mentioned that the facility might already be doing QI and that they just didn't know it. So basically, an endeavor, an intervention to improve your status from what you know as baseline to what you feel will be an improvement. It's actually part of the process. It's just there are a lot of names and labels for the things that is important in QI. And I'm now going to introduce you to the main man who's going to help us make sure that we implement these concepts properly and for us to be super familiar with quality improvement.